And thanks for joining us today for our media availability with DPH Commissioner Dr. Manisha Juthani. So, if after Dr. Juthani does her opening remarks, if you can just do the raise your hand feature, and I'll call on everyone as their hands are raised. So, Commissioner, I will turn this over to you.
Thanks, Chris. So hope everybody had a wonderful Thanksgiving long weekend, and thanks for joining us this morning. We wanted to take this opportunity to update you on where we stand in respiratory viral diseases right now, and particularly on flu. So I want to take a few moments just to talk about where we stand with flu in our state at this time. We have had close to 6,000 cases in the state so far that have been diagnosed and that we're aware of. There certainly may be cases that haven't been tested, as we know that there are no over-the-counter tests for flu. So if somebody doesn't go to attention, we may not know about that case. And we've had 102 hospitalizations so far for flu in our state. This is an early flu season for us. We have not had a flu season this early over the last 4 years, at least for sure, in terms of data that we have at DPH. And it is continuing to trend up. So we can only expect that it will get higher. Our last particularly bad flu season was in the 2019-2020 flu season. And for this time of year, we are far higher than any of the last 4 years in terms of flu seasons. So we wanted to bring this to people's attention because we know people have gathered with families over these last several days. If you're older, if you're sick, get attention because there are treatments out there, for example, Tamiflu, and you can also still get vaccinated if you have not been vaccinated this flu season yet, because cases are only continuing to rise. This is your opportunity to protect yourself and your family as we're going into this holiday season with many more gatherings to come. As we talk about flu, just to talk about some of the other viruses that we've been talking about. So for example, RSV. We know that RSV has particularly affected our youngest children most. We've had over 950 cases in the state based on laboratory tests. We know that our pediatric hospitals and ICUs have definitely felt the burden of this. Our highest number of cases have been in Hartford County, and it's very interesting because it has affected our youngest age group first, so 0 to 6 months, next 6 to 12 months, then looking at the 1 to 2-year-olds, then the 2 to 4-year-olds, and then we go to the 85 and older year olds. So it's really been affecting our most young and our most old in terms of RSV. In terms of influenza, we know that in general, age has been a major risk factor in general. And so we have certainly seen that as well. The burden of flu has been felt so far in Fairfield County, but we can anticipate, since the slope of flu is only on the upward trajectory, that this is going to continue to spread up and across the 95-91 corridor and across our state. So we are fully expecting that in terms of flu. Interestingly, in terms of COVID, our COVID case rates and hospitalizations have been relatively flat, almost going back till May until now. There's still a lot of COVID that is circulating. I know people who through this Thanksgiving holiday were diagnosed with COVID, so it's not that it's gone by any stretch of the imagination. But again, our most affected age groups in terms of COVID are our oldest age groups, 75 and older. Those are the predominant numbers that are affecting people who are ending up in the hospital. So again, one more plug for COVID and flu vaccines, which we know are our best shot at reducing severity of disease. It may prevent disease. It may not be completely protective, but it will certainly, especially for our oldest patients, reduce the severity of the disease going forward. So with that, I will stop and open to questions.
Great. Thank you, Commissioner. So if everyone who'd like to ask a question can raise their hand, use that feature, I will call on you. Commissioner, our first question will be coming from the Connecticut Mirror. Jenna?
Good morning, Commissioner. Could you talk about how the state will support the children's hospitals in the coming weeks and months? We've heard, at least one of the hospitals has been at or over capacity for months, particularly bad in the last 6 weeks. What kind of support is the state providing?
So we've been in regular conversations with our pediatric hospitals throughout these last several months. And we too heard about the rise in cases and wanted to make sure that they had resources available to them and to be able to support them. So some of the first things we did were to work with our hospitals and with the Connecticut Hospital Association, which helps represent the hospitals, to coordinate access to care, access to beds across the state. So if a given hospital is struggling, to be able to have another hospital help out if possible. Now we know with our youngest children, our pediatric hospitals are the best ones suited to be able to care for them. So because of that, we've also had meetings and collaborations with all hospitals in the Northeast where they are all assisting each other, particularly when it comes to ICU level care. That if there is the capability for one hospital, if there's a very, very sick child, to be able to send them to another place should it be necessary. Now, another example of what we've been able to do as a state is we have had hospitals come to us and ask for approval for alternate sites of care. So if they have a place in the hospital that might be suitable to be able to take care of a very sick child, they ask for permission from us. We as DPH then go out in terms of our safety team, first evaluates those spaces and then presents their recommendation to me as the commissioner to decide whether we should approve those alternate sites of care for children to be able to be cared for. So there's a rigorous process around that. We don't want to open up beds that wouldn't be suitable for a level of care unless it's really safe. And so that is one of the other things we do. One of the things that's challenging from a pediatric perspective is that we don't have a very deep bench of providers, for example, from the federal government. We may have people, for example, that are in the National Guard or in other places that could be brought in for adult care. But unfortunately, a lot of the people that have that type of skill set are already working in our pediatric hospitals. So that is a little bit of a challenge on that end. In a similar way, in our adult hospitals, we have been able to work with our hospitals and ask them to reduce the number of elective surgeries that they do for adult patients. And our hospitals have done that through COVID. Unfortunately, for pediatric hospitals, most children that need surgery generally need the surgery. They don't have an elective hip replacement or knee replacement or something like that that could be really put off for that much longer. So again, that's a challenge, but I also know that some of our hospitals have been able to situate older children, anywhere from 14, 15, 16, 17-year-olds as appropriate, so only as appropriate, to adult beds if possible, again, to make space for those youngest of children. One of the things I can say in our state so far is that the largest burden we have felt is from RSV. And although the burden is still there, we are starting to see a plateau in Hartford County and certainly a reduction when we look at the state overall. So I'm hopeful that with the various efforts that we've been able to support our hospitals with, we will be able to get them through that. As some of you heard in earlier reporting this season, there was a question of whether something like the mobile field hospital could be put up in front of one of our hospitals. Unfortunately, that mechanism, which we did offer, is really not something that's great for sustaining care over many, many months in the cold winter. It's really intended for maybe a disaster, maybe a week, maybe 2 weeks at most, with a generator in function, supplying heat to the area. And so, that although we do have that as a resource, it's really not something that we are able to sustain over a longer period of time. Again, we have worked with our hospitals, provided information about different contractors that can provide trailers and the like to be able to provide care in a more sustained way. And I will also be meeting with those hospitals again in the coming week or so to be able to identify what their plans are to be able to help take care of our youngest children in the state.
Could you just touch very briefly on the alternate sites of care? I know at Connecticut Children's, for example, physicians there have described utilizing patient rooms, perhaps hallways if needed, to scale up beds. Are you talking about on-site, or has the state had to look at overflow space?
So we don't look at overflow space outside of what they are approved in terms of their platform. So the type of example I'm talking about is, let's say, a sedation room. Now, that type of room might normally have been used to sedate patients that were getting ready for surgery or something of that sort. Our team would then go in and look at that particular space and say, okay, since it's been equipped to be able to provide sedation, it might also be appropriate for ICU level care for those types of children. And if our life safety team determines that it's been safe, then I get that recommendation, and I was able to approve beds in that type of space in that area where sedation would normally have been provided to those children.
Okay, great. Thank you, Jenna. Next up will be the Hartford Current. Ed?
Hi, yes, I am unmuted. Good morning.
Good morning, Ed.
I'm wondering if you have any theories as to why RSV is highest in Hartford County while flu is so far highest in Fairfield County. I mean, it seems like these viruses don't recognize county boundaries. They should probably be starting in the same places, you would think.
So it's very hard to know exactly what the reasoning is. What we can look at is the epidemiology of what we're seeing. With flu, what I have a more logical explanation for that, which is that we saw our southernmost states in the United States with the highest levels of cases first. So, for example, Texas and Florida. And we saw that that was inching its way up across the United States, going to the Carolinas, and now it's coming to the Northeast. And in general, flu, we know historically, affects the southern hemisphere first when it's their winter first, and then it comes to the northern hemisphere. And so as the virus transmits from the southern hemisphere and makes its way to the northern hemisphere, it's not surprising that it's going from the south to the north and migrating across the state in that way. So I think that is something we have historical perspective on to be able to offer why it seems like cases are highest in Fairfield and making their way up through the state. In terms of why RSV may be highest in Hartford right now, again, I'm reporting it based on the way that we report these data right now. And, those data are going to be transitioned to more of a regional model rather than a county model as we go forward based on changes that have happened at the state level. And that's why I say that in Hartford County right now, our numbers are the highest, because that's where the way that we're reporting it. I agree with you that these viruses don't certainly abide by any borders of state or county or city for any means. But why would RSV be highest in Hartford? I don't entirely know, other than to say maybe that there was some introduction and then connectivity of children of a certain age group that allowed for the virus to spread in those communities. And that's probably the best I can come up with, which is why it's, sort of had its stronghold in the Hartford County, but certainly been throughout the state as well.
And when you said that the flu season starts in the southern hemisphere, are you using that data to predict how bad it will be around here, and can you be a little more specific about how much flu we're going to see?
So I can't be specific on how much flu we are going to see, but yes, you are accurate that in general, flu season is modeled over for us is modeled over what we see happen in the southern hemisphere. And so, each year the vaccine is modeled over what happened the year before, with the hope that there isn't too much of a mutation from what we saw the previous year. And these are concepts of antigenic shift and antigenic drift. And what we're looking for is just a little bit of a drift and not a major shift in the way that the virus mutates. And so what we can see through this particular winter season is that in the southern hemisphere, cases were more severe. They did have some high numbers relative to previous the flu season was higher than it has been compared to previous flu seasons that we've seen over the last several years, probably the last 4 years or so. And given that we have not had our peak yet in Connecticut, and given that our numbers are the highest they have been over the last 4 years, I certainly expect us to reach highs that we had similar to the 2019-2020 season, which was a particularly bad season before actually COVID came. And so what I can say is that We're looking at a relatively bad season, and we can do the things that we know to protect ourselves. And if you get the flu, get treatment if you are eligible based on your doctor's assessment, because it may help you get better earlier.
If I could just ask quickly, what strains of flu are we seeing?
We're seeing mostly flu A and the various different variants of that, so H1N1 and the like. And so usually we see A earlier in the season and B may come later in the season. We do still see some B as well, but we are certainly seeing a lot of influenza A right now.
Thank you.
Okay, up next, Hearst Media.
Hi, Commissioner.
Hi, Jordan.
I was just wondering because I noticed that the hospitalizations from flu are not just case rates, but hospitalizations from flu are also significantly higher than they have been in previous years. I just wonder if this is a particularly bad year in terms of the ability, like, are hospitalizations worse in comparison to the case rates, like the percentage of cases per hospitalizations, if that makes sense?
Yes, you're basically looking to determine whether severity of disease this time around is worse, resulting in hospitalization.
Thank you.
And I think I think what we can say in general is that for the number of cases that we have and for the number of hospitalizations. So as I said, we've got close to 6,000 cases in the state that are diagnosed and 102 hospitalizations so far that have been identified. That is a particularly bad year in terms of hospitalizations for us. So often we can't say for sure the answer to that until we get more data over the course of the year and we can really look at severity. But I would say overall that those numbers do suggest that that could be the case. And we will, continue to evaluate that as we go forward. But when we say that this is a particularly bad flu season, that's just based on the numbers that we can actually capture. As we know, we don't have over-the-counter flu tests. Not everybody who gets the flu actually gets a test. And so what we know is we have the number of tests that actually come to DPH. We have the number of hospitalizations that we actually can track. And that then gives us a sense of how bad the flu season is going to be. So to your question, I do think that probably we do have some increased severity of disease because our hospitalizations are at the higher level right now. However, if over the course of this season we see those numbers come down in terms of hospitalizations, but the number of cases persists for some period of time, overall it may not turn out to be that way. So I would say for right now, I would agree that we are in the midst of a bad season.
So, I mean, in terms of the severity of disease, I'm curious if there is greater severity of the disease because so many of us have had COVID and our bodies are still fighting those, the long COVID and the results of those infections over the course of the past 3 years. Are we experiencing flu? Are our bodies not fighting the flu off as well because of COVID and previous COVID infections?
I think that's a tough question for us to know the answer to just yet. What I would say is certainly, long COVID is real. Long COVID is something that there are many people that are suffering from. We do have preliminary data to suggest that vaccinations, boosters, staying up to date in your boosters can reduce the risk of getting long COVID. And if you get treated for COVID, so particularly if you're older and eligible for Paxlovid or Molnupiravir or antibody treatment, whatever it may be, your chances of long COVID also appear like they might be less if you get treatment. So our pool of people, hopefully over time, that have long COVID may reduce, and that would be a good thing in terms of a long-term problem that we have in our society. Now, what we don't have good indications of is that it is people who've had long COVID that are getting bad flu. We don't have data to actually say that yet. That's certainly a hypothesis. It's a testable hypothesis, and I'm hoping that there are studies that are done to show us that are there people who are getting bad flu. Did they have long COVID? Did they have multiple bouts of COVID? Are they people who are susceptible? I don't know of data that really suggests that as of yet. What I can say is that our oldest folks are certainly at most risk of flu, as they always are every flu season.
Okay, great. Thank you, Jordan. Up next, Fox 61, Lindsay.
Hi, Lindsay.
Hi, how are you? Can you hear me?
Yes, kind of quiet if you were able to speak up a little bit.
Okay. Oh, okay, great. So could you just repeat the data for the flu? What are the age groups of who's testing positive for this? And have you been in contact with the school? Are they doing anything to help mitigate the spread?
What was the last question? I couldn't hear that well in terms of who was what?
Have you been in contact with the schools?
Oh, I see. Yes. Okay. So, so a few things. What I would say is that we've had close to 6,000 cases. We've had 102 hospitalizations. Those that are most affected in terms of coming to the hospital still are our older age groups. And that doesn't mean that, as we've seen in other states throughout the country, that there have been flu outbreaks with outbreaks in certain classrooms. What we have been doing ever since COVID is that we have been having regular meetings with our schools, but even before COVID, when there would be an outbreak of a particular classroom or something like that, those schools would be in touch with DPH and coming up with the mitigation strategies that everybody is very familiar with in terms of what works have been things that we've been doing with the schools. So the schools and their superintendents have been meeting with DPH and with the Connecticut Department of Education on a weekly or every other week basis as needed, and continue to email with us as they have outbreaks and as they have questions. So we have continued to work with them if there is a particular school or classroom where there may be either a COVID or a flu outbreak, and how to help mitigate that and then deal with that in that particular school. So we don't have situations where we need to do anything on a statewide level or things that resemble what we did in COVID in the past, but we continue to use mitigation strategies as needed, including recommending potentially closing a classroom for a few days if needed. And the schools really make those decisions based on staffing and other things that they have if they need to go to that extent.
Great. Thank you, Lindsay. Next up, News 12. Sean?
Hi,
Hi,
Sean.
Commissioner. In terms of hospital capacity, there have been times during this COVID pandemic that all hospitals, it seems, were at about 90 to 105% capacity. Where are we now in terms of these respiratory viruses circulating? Is there any danger of being overwhelmed?
So I think what we felt most over the last several weeks was capacity limits at our pediatric ICUs. And since then, that has still been high. So there's no doubt that we're still in the 80 to 90% capacity of our pediatric ICUs. But in terms of our pediatric beds, we're in the range of 80%, 80 to 90%. And I think in terms of our adult capacity, we also have been in that range of around 80%. So there's been various different ebbs and flows in different areas through the state. But at this point in time, our hospitals are most certainly busy, but they are hanging in there and ready to take care of patients.
And if a patient has both, say, flu and one of these other viruses, whether it's COVID or RSV, is there any additional concern? Would there be an additive or a multiplicative effect there?
So, I think when first COVID hit, we had a lot of fears about COVID and flu, and we continue to monitor for that. Interestingly, there's a very small group of people that actually have COVID and flu together at the same time. We suspect that it may be worse to have more than one of them at the same time, but I think that there's more and more data that's continuing to come out from the scientific community to be able to answer that question of whether having both is worse than having just one of them. Certainly, intuitively, it makes sense that if you have more than one thing that's attacking you at once, that it may be additive in that way in terms of your response to the infection. But interestingly, in terms of COVID and flu, those numbers have been relatively small in the state. And likewise, interestingly, RSV affecting our youngest children most, as I said, we have RSV sort of highest in the 0 to 6 month old, and then 6 to 12, and then 1 to 2 years, and 2 to 4 years. And then the next age group is the greater than 85-year-olds in terms of, who the number of cases. And even the greater than 85-year-olds is a very small number in our state. But you can imagine that if you're greater than 85 years old, and you get RSV, the flu, COVID, or any combination thereof, it's likely to be worse. So, we always have to be watching out for our oldest age groups because they're going to be the most susceptible to everything.
And one last thing, I know uptake on the flu shot has been a little bit slow this year. Do you have any numbers on that?
Yeah, so we are roughly at about 50% for, again, our oldest age groups when we're looking at greater than 75 years old, greater than 65 years old. So I think our oldest age groups are getting this message that, viruses are bad for you. And as you get older, you're more at risk. But what we do know, we know that certainly older people's immunity is only so much, and their ability to develop immunity to the vaccine is only so much. And so we've all heard this before in terms of herd immunity, reducing the amount of virus that's spreading. Everybody can play their part, and you can certainly do that in terms of protecting the older people in your family for both COVID and flu.
Okay, next up, Connecticut Public. Matt?
Hello, doctor. And I apologize, I joined late. So what's the biggest concern for children right now with these three viruses, three illnesses circulating?
The biggest concern for children really under the age of 4 is still RSV, I would say, in the sense that, we are seeing the numbers still quite high. This is the highest RSV season that we have had in 5 years. It is earlier than we normally see RSV. I'm hoping that does not mean that we see another peak later in the season. I am hoping that we're just going to get it early, and maybe that will be it. But, I think one of the things for parents to remember regarding RSV is certainly for children under 6 months of age, this is the biggest at-risk group, but going up to 4 years of age. And one of the things about RSV is that it is often transmitted through surfaces. We learned through COVID that COVID less so, but RSV really is transmitted through surfaces. So if there's a take-home message for parents of young children, is that when you have them playing with other children and kids put things in their mouths and they're touching things everywhere, and you have snotty kids and you have secretions going everywhere, that's a recipe for RSV to spread. And so if you have a child who's in that category, that's a good time to keep them away from other children, because that can really be a spread of RSV. You don't necessarily need to make a diagnosis of RSV, because unless your child is really having difficulty breathing and needs to have their airways opened up with breathing treatments or needs other assistance that would be offered in a hospital, there's not really much else we can do. And so I think for the youngest children, it is still our greatest risk. But again, I don't want to underestimate the threat that flu and COVID can do. So, a couple of weeks ago, we already had 3 deaths of children from flu in the country. That number is probably higher now. And I think, it's a simple thing to do to get your child vaccinated against the flu and COVID. And we just don't know. We cannot accurately predict, although, of course, immunocompromised children are always more at risk. Children with asthma are going to be more at risk. But your child may or may not have a bad case of COVID or the flu, and getting vaccinated is something you can do to mitigate the severity of disease, even if they get one of those infections.
And is there any concern about RSV sort of causing illnesses and potentially staffing shortages, either among daycare staff or among educators? And is there any sort of action being taken to protect them?
So again, the greatest risk for RSV is in the 4 and under age group. Many daycares are fully aware of this. And, many providers are taking the measures that we all know, to protect children and staff in facilities. So many facilities have decided they're going to continue to mask because it works. And they know that they are doing that to try to protect often their staff and their workforce, and to be able to get through this. For the youngest of children, that's a very difficult thing to do. But, again, we as DPH remain as a resource to be able to instruct people on the various things that can be done. Many facilities have worked on improving ventilation. We've talked about hand hygiene. We've talked about all the different metrics that are in place. But we know that masking works. And so for facilities that are particularly vulnerable or at risk, or maybe have an outbreak going, many of them have chosen to ask for masking in their facilities to be able to help keep people safe at this point in time.
Thank you very much.
Okay, we're going to go back now to Hearst Media. Alex?
Yeah, hi, and Commissioner, thanks for doing this. You touched on this a little bit earlier, but the conventional wisdom had been that COVID would kind of surge again in the winter. I am curious from your understanding if that is still the conventional wisdom, or if you think what we have seen in the last few weeks and months has made that seem less likely to happen.
So I am still of the belief that COVID will surge. I think that what we're seeing is that RSV took off early and seems to be coming down. Flu has taken off early. We have not peaked. We don't know where and when we will peak. Again, COVID, we continue to learn about this virus as it plays itself out. This is the first season we've had with all these viruses competing with each other. My guess is that we will still see a COVID peak, maybe more in January and February. We know for the conditions in the Northeast, the winter has traditionally been that period of time when we see the surges most. I guess I'm happy to be surprised and proven wrong if that turns out not to be the case. But given that we are continuing to follow it and continuing to monitor it, I would suspect that it will take its peak after these other two viruses peak. And that what we're seeing is the first season of what these viruses want to do when they're trying to outcompete each other. Having said that, I cannot say for sure. I don't know, but that would be what I would suspect will happen. I'm happy to be proven wrong. I'm happy to find out that COVID is just going to be around consistently and persistently throughout the year. I still would hypothesize, though, that it is going to be higher this winter at some point. And my guess would be in January and February.
So last winter, I mean, we set record numbers of new cases. We had nearly 2,000 people hospitalized with COVID at one point. Are we prepared, or what is your department doing to be prepared if that happens again on top of the transmission of these other viruses?
So we've been working with the Hospital Association and with our hospitals for many months because I've been very concerned about this. So obviously the best way to do that is to get people vaccinated. As you all know, we've been pushing this message very strongly for many, many months. And I'm going to say it one more time that it is not too late to get vaccinated against the flu and COVID. And that would be for all age groups, but certainly for our oldest patients, because what we can see with COVID is that it is the 75 plus year olds who are getting hospitalized consistently. Even now, even since May, it is that oldest age group that is our biggest number of patients that are in the hospital. So having said that, what are some of the things that we are doing with our hospitals and hospital association? We started meeting with them early on to be able to identify what kinds of things they were doing in terms of their system. So as I mentioned, in terms of alternate sites of care, I've already been approving alternate sites of care in hospitals as the adult hospital beds are looking for different places within the hospital where they can care for patients. So our team goes out, identifies whether a given area would be suitable for patients to be cared for, and then my team will present it to me and decide whether it is appropriate to approve these alternate sites of care in a hospital. Secondly, we've been talking with our insurance providers, with our hospitals, with our nursing homes to be able to figure out how are we best going to be able to help facilitate transfer of patients from the community to the hospital, back to long-term care, back to home, so that it's not that patients are waiting in the hospital for longer periods of time. We need the entire healthcare system to be working together, and so that it's not that patients are just waiting for insurance approval, for example, to be able to move to another level of care. And we learned that through the last several years of COVID, that can sometimes be a rate limiting step. So that's an example of the type of thing we've been working on. We've been working with our providers to make sure that they have staffing to be able to take care of patients, and also working with our federal partners, for example, ASPR, which is the preparedness organization that can help provide other staff. For example, if there's an area of the country that may not be having a surge, but we all of a sudden have a surge and we are in desperate need for additional providers, being able to tap into that resource quickly And we know how to do it because we did that last season. And we as a department know what to do to be able to ask for such a resource from colleagues around the country and from our federal partners. So those are just a few examples of the types of things we're doing to be able to try to be as best prepared for this respiratory season as we continue through it.
Thank you. I appreciate it.
Thank you.
Okay, I'm just going to circle back. Jordan, do you have another question, or was your hand raised up there?
It was raised by mistake.
Okay, we're going to go back to the Hartford Current. Ed?
Hi again. I just wondered if you could name some of these alternate hospitals that you're approving for taking cases.
So it's not alternate hospitals. So
Oh.
what this is within a given hospital footprint. So we need to go within what the certificate of need is for a given hospital. It's the number of beds that they're approved to be able to take care of patients for. But for example, there may be an area that used to serve as an outpatient clinic, or it used to serve as an area where maybe chemotherapy was infused. And it's not being used for that purpose right now, or it's not being used for that purpose because they would prefer to have emergency department overflow go to that area of the hospital that normally would have been used for another purpose, but now they want to use it for emergency room overflow or for ICU care or for inpatient bed capacity. And so those are the kinds of spaces. So they're already clinical care spaces. They're just not being used for inpatient bed capacity. And that's why we have very strict guidelines as a department of what is a safe area for a patient to be cared for on an ongoing basis. It needs to meet fire safety codes and a number of different codes that are in place to be able to say it's safe for a patient to be cared for there. And so when a hospital is reaching capacity in its normal spaces before it gets there, it comes to us as the Department of Public Health to be able to go out there and say, can we use this space? Because we want it to be a safe place where patients can be cared for. And those are the kinds of places that I mentioned. So I mentioned before a sedation area. Maybe it's an overflow clinic space. Maybe it's an area that was a patient and family conference area, but has the capacity to be able to provide medical care as well, because it was built with that in mind, that it could be an overflow space. So those are the types of places that I'm talking about. There are no alternate hospitals in this state. That type of structure does not exist. So I don't want to give anybody any sort of false illusion that we're putting up some, new hospitals or areas that have not already been approved for certificate of need.
Yeah. So there would be no possibility for patients from Connecticut Children's to be put in Hartford Hospital if there was a real surge.
So that's a different scenario. Hartford Hospital and Connecticut Children's have arrangements and memorandums of understanding between the two of them. And that's an arrangement that they could work out among themselves. So what I was saying before, earlier in the beginning, I talked about the Connecticut Hospital Association serving as the go-between to help identify not just Hartford Hospital and Connecticut Children's, for example, but potentially a transfer of a patient from one hospital in the state to another hospital in the state, or patients going from an emergency room in one part of the state to another state, another hospital in the state, sort of diverting their patients to a different hospital because they have a partner who is accepted to take patients from them because they are at capacity. So that type of infrastructure already exists, already happens all of the time. That is usually done at the emergency department level. The alternate sites of care that I was talking about is when a patient needs to be admitted for inpatient care and a hospital is looking at how they're going to take care of that patient, and are there different areas within the hospital where maybe they could care for that patient.
Okay, thanks again.
Okay, great. Well, thank you everyone for attending today. Just one reminder, we sent a release out last week. The local health departments around the state are also offering flu vaccine clinics. So ct.gov/DPH, we had the link right at the top of the DPH page, if you can mention that as well. But in addition to pharmacies and other locations, local health departments are offering the vaccines. Any other questions, you can always email or text me as usual. And Commissioner, thank you very much for today.
Thank you, everybody, for joining us this morning.
Thank you.